Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Welcome to Dialogue with the Doctor. My name is Dr. Gregory Leach, and this is a show where we interview specialists and talk about their craft, specialists in medicine. And this evening, now we have Dr. Raymond Phillips. And this is going to be, Dr. Raymond Phillips is a practicing gastroenterologist, and he's going to tell us about his training briefly. But we're going to be having part one segment on irritable bowel syndrome and what is irritable bowel syndrome, which, that's a good question. So
yeah,
tell us about you, and then tell us about what IBS is.
Well, absolutely, Greg. Thanks for having me again. And I just wanted to introduce myself. I'm a gastroenterologist, a board-certified gastroenterologist. And what a gastroenterologist is someone who's gone to college. I went to Princeton, graduated, went to medical school, Washington University, St. Louis, did my internal medicine training over a 4-year period, was chief resident. Because I'd gone through Princeton on an ROTC scholarship, I went on active duty at Fort Leonard Wood for 2 years as an internist, and then I did my training at Walter Reed in gastroenterology for 2 years, and then I was on staff at Walter Reed for 2 years. And then I came, when I finally left the Army in 1991, I came down to Naples, and I've been practicing here ever since. And over the years, our practice has grown, and there's 6 of us now, myself, Dr. Libursky, Dr. Marks, Rivera, as well as Hara and Dr. Urbina. And we have offices in Naples as well as in Bonita Springs and Marco. But getting back to the subject that you're mentioning, irritable bowel syndrome, is really quite a widespread issue across the United States and indeed across the world. And over the last 30 years, our understanding of this condition has really undergone an evolution that has been quite dramatic in terms of our understanding. But it's worthwhile to really have an appreciation what irritable bowel syndrome is, because over the years it has been described as different conditions. In the 50s and 60s it was called spastic colitis or spastic colon. Then the term irritable bowel syndrome was introduced, and our understanding about the potential causation evolved from one of stress or stress-induced gastrointestinal issues to one of concern about increased motor activity, and then an understanding that there was increased sensitivity of the GI tract toward discomfort. And now much of the research is looking at alterations in the microbiome, that bacteria within the gastrointestinal system, the colon in particular, that may influence irritable bowel syndrome. But regardless of the cause, we've been able to define the nature of irritable bowel syndrome, and these definitions have evolved from a meeting in Rome that occurs periodically, about every 5 years. And the most recent one, the Rome Forum Conference this past year, really has helped refine our understanding or release our definition of irritable bowel syndrome further. And refine it to the extent that there's many gastrointestinal complaints, all the way from upper abdominal discomfort to lower abdominal discomfort, and we're learning that there's many different conditions, and irritable bowel syndrome is just one of these. Irritable bowel syndrome is defined into 3 general categories: a variety that's constipation predominant, a variety that's diarrhea predominant, and an intermediate group that will go back and forth between extremes. And with all those particular camps, if you will, or varieties of irritable bowel syndrome, there'll be circumstances in terms of abdominal discomfort characterized by cramping with relief, or at least reduction in terms of the cramping with having bowel movements, a change in frequency of movements with onset of pain, and oftentimes issues in terms of bloating or distension that are part and parcel of this. So that's been the general definition of irritable bowel syndrome, and these are symptoms that have prevailed or are ongoing for the last 6 months, in the absence of any other major medical condition. And so that's our clinical definition, and that definition has been very useful for allowing us to categorize individuals with gastrointestinal issues, or gastrointestinal complaints, and allowing us to direct our efforts in terms of evaluation.
So is this just a disorder of function, a functional disorder of the bowel, meaning if you study the bowel, it looks normal, it's just not behaving normally?
That is exactly right. And that's one of the definitions, but unhappily, the term functional has a kind of negative connotation in medicine. But in terms of its true meaning, that is to say, there's no anatomic abnormality that can be demonstrated, but nonetheless there are symptoms that are present, and there are reproducible symptoms, reproducible to the extent that the individual has these symptoms again and again, that really are valid and meets the definition of a disease in the sense that a person is suffering from it, and there's potential way of giving improvement or directing improvement toward these symptoms. Now, and that's a key point, the efforts in terms of treatment now are not so much, since there's not a defined anatomic abnormality, which it strikes the very nature of what we do as medicine. Medicine was defined, hey, we would evaluate people on an anatomic basis, find an abnormality, and that would be the basis of the disease. With irritable bowel syndrome, there's no defined anatomic abnormality, so there's no condition to cure, as it were. And so the efforts now have been directed toward what can be done to improve the symptoms. What can be done to improve the symptoms? And based on that, that has directed the kind of treatments that have become available over the years. So for example, a person has crampy pain. The thought is, well, maybe it's because of increased intestinal contractions, and we developed anti-cramping medications. Anti-cramping medications that diminish the intensity of contractions. Those medications work pretty well, but they didn't relieve all the symptoms. And then other varieties of symptoms, such as, hey, a component of irritable bowel syndrome is diarrhea. Well, if we slow down the number of movements, that will help in terms of causing relief of that symptom. The other extreme is constipation. Hey, if we give an individual various laxatives, that can improve that symptom. So much of the treatment for irritable bowel syndrome has been symptom directed over the years in an effort to try to minimize those symptoms. So it's been but since we didn't really have an understanding of the illness itself or the condition itself, the treatment that physicians have prescribed has been a little bit haphazard, if to the extent that if a gastroenterologist has difficulty in terms of describing it or defining it, it becomes difficult for general practitioners in the context of a busy practice to be able to describe and prescribe in a meaningful fashion to a patient the best way to treat this or address this or to understand it, for that matter.
That makes it real easy.
Yeah, that makes it real easy.
It's difficult.
Yeah. So suffice it to say, yes, we have a good definition of irritable bowel syndrome. It's not a disease that progresses into anything worse. It does oftentimes run in families. It can be a lifelong condition, but it doesn't necessarily mature into something worse or change into something worse or make you susceptible to cancer and to any other conditions.
So the link between stress, for lack of a better word, or people who feel stressed and IBS. I mean, I know we're hardwired to the gut through one cranial nerve. It's the only one that goes below this level, the 10th cranial nerve. Is that where the direction comes to stimulate the intestine when people are stressed out with IBS?
Well, and you're right, and in the sense that there is a brain-gut connection, and your GI tract really closely reflects your emotional state, and that's ongoing, and the GI tract can be influenced by direct neurological inputs like what you're describing, or other inputs such as release of certain hormones into the bloodstream. Like, for example, if you're frightened or scared or anxious, you'll release a lot of hormones such as adrenaline that can really stimulate the GI tract as well. But not only is there a direct connection in those sense, in terms of connections of chemicals such as hormones or direct, is that what we're learning is that there's a bi-directional communication. That is to say, it's not one-dimensional or one way. That is to say, the brain to the GI tract. It also is from the GI tract to the brain. And what we're learning is all individuals that have irritable bowel syndrome have an increased sensitivity of the GI tract to normal physiologic processes. So, for example, they can perceive distension better than other individuals. And that distension to them can make the transition to pain more readily than other individuals. So there's and we call it visceral hypersensitivity, but basically they can feel things better than other individuals. And that increased sensitivity makes it very difficult for them because when a usual amount of intestinal gas that might not bother an individual in general can, in individuals with irritable bowel syndrome, cause a lot of sensation of discomfort and bloating and cramping as well. So yes, indeed, stress has a role in terms of irritable bowel syndrome, but its role is one more of a triggering function in terms of triggering symptoms rather than actually provoking the underlying condition. As I tell my patients, even if they lived in a beach in Tahiti, they would still have irritable bowel syndrome. So even though you can eliminate any kind of stressful extrinsic factors, you'd still have irritable bowel syndrome. You'd just be at a beach in Tahiti with the same condition. So it's a little bit of a frustration when you're thinking in a simplistic fashion. Oh, gee, this person is causing stress in my life. If I didn't have that stress, everything would be wonderful. So no, that kind of understanding is what initially made us, or that kind of impression initially made us think that psychological issues were the preeminent cause. And it's clear that that's not the cause of this condition. The cause, in fact, is a little bit difficult. As I said, we understand there's increased sensitivity. We have noticed and measured that there's increased motor activity. But an area of intense research right now is that alterations in the normal bacteria within the colon and small intestine may underpin or may underlie why individuals develop irritable bowel syndrome. And those subtle alterations in bacteria can interact with the nerves in the small intestine and colon, and in turn cause a feedback abnormality and lead to irritable bowel syndrome. So that's why there's such intense interest right now in terms of the microbiome and the constituents of the microbiome, such as the bacteria within the microbiome. And that's why this interest has been picked up and reflected in the use of probiotics by the probiotic industry, as well as individuals interested in probiotics, trying to use probiotics as a way of influencing bacteria that in turn can favorably influence irritable bowel syndrome. But it's a real frustrating area in terms of research, and since the fundamental research is now ongoing. But I don't want to leave our viewers in despair, and particularly those individuals with irritable bowel syndrome. We have made great progress in terms of developing more specific treatments in terms of addressing irritable bowel syndrome, constipation predominant and diarrhea predominant. And we can talk more about those particular therapies, and by using them in a strategic sense, we can make a great difference in terms of an individual being able to function more effectively and not being sort of hampered by this condition. And so, to sum up in the short term, yeah, you have irritable bowel syndrome, a condition defined by these symptoms, and it can be troublesome. And there is a number of clear-cut physiological abnormalities that are present within this. So it's not a condition that's in a person's head. So it's not a circumstance or stress or a psychological issue, which was one interpretation in the 1950s. doctors would ask them about their relationship with a mother, and that was. But now we've we've had a little bit clearer understanding of the physiology, and as a result, we've been a little bit more effective in terms of developing newer treatments in terms of symptomatic treatment, which we'll discuss in just a moment, but also trying to get a better understanding of the actual cause or the physiology, so we can be more effective in the long term in terms of developing long-term solutions for people.
Well, thank you, Dr. Phillips, and we will be continuing this discussion. This was segment 1, and we'll be going on to segment 2 in just a few minutes, and you need to come back and join us for that. Thank you for being with us on Dialogue with the Doctor.
All right, thanks so much, Greg. Thanks.